I would like to welcome everybody. Thank you for coming out today. Today we're with Next Level Physical Therapy, or Physio, up in Woodcliff Lake and Montclair. Today we're speaking on behalf of all the parents out there, all the parents that have daughters and coaches that have students and participants in youth and adolescent soccer. In this demographic, there is what we call an epidemic of ACL tears going on, and as much information as we could glean and as much, ways that we could try to figure out how to avoid and really improve the outcomes of these injuries. That's why we're having this presentation. I would like to introduce you guys to Dr. Nick Doss. He's one of our physical therapists. He's taking the lead in terms of sports injuries amongst the adolescent population, and is currently working with the MSU, the Montclair State women's soccer team, as well as Dr. Pelivan. He is with Preferred Pediatric Orthopedics in Ridgewood, New Jersey. He is going to be speaking about the surgeries and other issues in terms of the medical procedures with ACL tears. I'm going to share my screen, and we will start the presentation with Dr. Nick Doss.
All right. Thank you, Dave. Thank you for everybody being here tonight. PJ, thank you very much for having us. It's always a good time coming out, doing whether it's a webinar or, any of the workshops we've done in the past. It's always a pleasure. So today you're going to be talking about the 3 absolute musts of ACL rehabilitation and other soccer injuries. We're really going to hone in here on ACL rehab today. And the reason being is we've done talks about prevention in the past. In this next slide, you'll be able to scan QR code from our owner, Dr. Jerry Yu. He put out an ebook on ACL prevention. You can scan that, and there's an ebook there for you to download on ACL prevention. And if anybody wants us to come back and do another talk, you just bug PJ, and we'd be happy to come back and do one. Dr. Pelivan is going to be chiming in as I present on some of the points that I'm making. But with that said, let's get right underway. So again, we are Next Level Physio. We share a partnership with NJ Crush. And really what we look to do for NJ Crush is to serve as a resource for the families. In the past, we have come out, and you can see in this picture here, we have done ACL risk assessments for a bunch of the players. If you have a kid who is injured or is just looking to get better on the field, you just let us know in Next Level Physio, and we are here to help in whatever capacity. A little bit about myself before I get started. I'm, again, a PT at Next Level Physio, graduated from Rutgers with a degree in kinesiology, got my doctorate from NYU. On top of being a PT at Next Level Physio, I am the lead strength and conditioning specialist for the Montclair State's Division III women's soccer team. I'm an avid ACL rehab enthusiast. I care a whole lot about the process of what happens when a kid tears their ACL all the way to getting them back onto the field. It's one of my favorite rehabs to do, and I've taken a lot of interest in it in my career. And my goal overall is to help people, whoever I see, develop a better relationship with health and exercise through movement. So our goals here tonight. So again, we're doing this discussion from a preemptive standpoint. I want you guys to know the importance of ACL rehab when an ACL tear occurs. Because if we only ever talk about prevention, it's kind of like the same way you get insurance on your house because you're worried something may happen. With a group of adolescent soccer players, female soccer players, it's a high-risk group for ACL tears. And to plan for the emergency after it happens is not the best way to go about it. So we're going to do that. Dr. Pelivan's going to chime in for the anatomy education tonight. I'm going to take you through the sequence of events of what happens when the ACL tears and what to expect. And Dr. Pelivan can chime in there too. And then I'm going to talk about the 3 rehab musts that will increase the likelihood of being a successful outcome. So we can go to the next slide, Dave. So the reason why we're doing this call tonight, again, like Dave said before, there is an overwhelming epidemic of ACL tears that are happening in women's sports, but the highest prevalence that we are seeing is in women's soccer. And if you need a good example of that, you can look at this year's U.S. women's national team. But if you look at the 2015 U.S. women's national team roster, 64% of those players had torn their ACL at some point or were going through an ACL tear. And how does that, if that's happening at the highest levels, we'd have to imagine that even when it trickles down, it's going to be happening at all levels of soccer. So really good example of that is in high school. Every year that your child plays soccer year round, if they are a female soccer athlete, they have a 5% chance of tearing their ACL. If they play all 4 years, that is now a 20% chance or a 1 in 5 chance of tearing their ACL at some point in high school. And I think that that alone is an alarming statistic, but the fact that 55% of people or athletes return to the competitive level of sport after ACL tear, that means if your child tears their ACL, it's almost a coin flip whether or not they get back onto the field. That 55% there is including professional athletes. When you take the pro athletes out of there, that number now comes down to, I think, like 42%. So it's worse than a coin flip. And again, ACL tear prevention is paramount, but again, not all tears are preventable. So like we have to talk about contact tears. It's just always a chance. So it's important for us to have an understanding of the importance of what to do when a tear occurs. Again, this is a very high risk, high brood of knowing somebody who's going to tear an ACL. So it's important that, it's an obligation for everybody here to listen to this call for their kids in case something happens. And again, successful recoveries are really just better than a coin flip. And I think that the alarming part of this is if a child tears their ACL and makes it back to sport, or an athlete makes it back to sport, out of all of those recoveries, it now shows that 30% of those recoveries are going to suffer a secondary ACL injury, whether it's tearing the same side or tearing the opposite side. So if half of kids who experience the first tear make it back, which is already too few, 1/3 of them that are going back to sport after that are going to suffer another injury. And I think that those numbers are a reflection of deficiencies in our field in physical therapy. I think that we could be doing a better job from beginning to return to sport. And it just takes a more involved rehab process. Female athletes are more likely to tear their ACLs than their male counterparts, but I'm going to hand this part over to Dr. Pelivan, the anatomy of the ACL.
All right, thank you. Welcome everyone, and thanks for chiming in. So the anatomy of the ACL, the knee joint is actually a very complex joint. From what we see, it does two functions to the normal person when they watch a knee, that it flexes and extends, and that happens when we run, when we kick. But there's actually a lot of different motions going on in the knee that you can't really tell from the naked eye. And the ACL is a very important centralizing ligament that basically is a check rein to these motions that occur at such high forces when you're running, sprinting, changing directions, decelerating, etc. And so when it is torn, its function, and I have slides later on that I'll go over and show these specific motions, but when you have a deficit ACL, your knee is susceptible to so many different forces that new injuries and further injuries to the meniscus, cartilage, etc. Will happen inevitably. And so this ACL is so important to keeping the kinematics or the motion of the knee as perfect as possible, so that we can do the incredible things that we do as athletes, especially your daughters, playing at such a high level. So it's a very important centralizing piece to that. So and it's a ligament. It's inside the knee joint, and it's therefore it's not something that can heal on its own because its blood supply is very limited. Generally, when you tear the ACL, you've also torn the very tiny blood vessels that supply it, and they get damaged and they can't repair themselves. And that's why it's something that you have to have surgery for to reconstruct. Ligaments outside of the knee that are surrounded by muscle and other blood vessels, like the MCL and LCL, generally have a better time of healing without surgery than an ACL because of the blood supply. So that's the biggest thing for that. Now I'll get further into that with my slide, so you can continue on. Next.
Yeah, Dave, you can go to the next slide. That was awesome, Dr. Pelivan. Dr. Pelivan hit on a lot of the points of these next slides. I encourage you guys, today we will talk a little bit about the factors that can predispose female athletes to an ACL tear, but I think Dr. Jerry put together a great ebook, which you guys can get on that first slide, and we'll make sure these slides get sent out to you. But
I touch on that as well in my slides. I have a few things. So
yeah.
No, so I'll get to it when I'm in my part. Yeah.
Gotcha. Something Dr. Pelivan touched on was the anatomy, Q angle. So we can see that when the female athlete hits a pubescent age, the hips get a little bit wider, and then we'll start to see knees start to collapse in a little bit or cave in. And if you go to the next slide, Dave, you can see that there's something called valgus. So if you watch enough games, you will inevitably see some players' knees cave in. Now, from a physical therapy standpoint, if you go to the next slide, a general rule of sport is you do not want to go into a position that you are not strong enough to get out of. And again, I think Crush does a very good job with prevention, from their FIFA 11 warm-ups to having us come out and do some programs to get the kids stronger. But soccer is a sport where there's a lot of deceleration, pivots, quick directional changes, and landing on a single leg. If the wider hips are causing these to dive in more, the female athlete just has more of a reason to double down on strength training to make sure that they are strong enough to survive the sport of soccer. So we can head to the next slide. We can go to the next one too. So we're going to talk about the sequence of typical events post-tear, and Dr. Pelivan, you chime in wherever here. So I think I put a checkpoint in here. Yes. So I see we got a few new participants. So I put this in here as to, just in case we had any late joiners. So today we're talking about ACL tears. We're talking about why we are talking about when it tears versus prevention. NJ Crush is taking great proactive steps for their players. We can never really remove the risk of a tear, especially a contact tear. So with that information there, we should be talking about how to prepare if an ACL tear occurs. And I think Dr. Bellman can attest to this, and so can Dr. Dave. Patient expectations and the results that are happening after the surgery, from either surgical outcomes or rehab outcomes, they're just not matching. And we're going to get into a whole slide on where these expectations are falling apart. But I feel like if we do a better job of educating on the front end, we're going to just avoid subpar rehab results that make not successful outcomes by talking about some of these things on the front end. So we can go to the next slide, Dave. So the sequence of events that happen here are, for one reason or another, whether it's a contact injury, meaning the athlete was contacted by another player, or a non-contact injury where they planted their foot, twisted, and heard a pop. They're going to hear a pop, they may fall down, and there may be a ton of pain where they're on the grass screaming, or there may be no pain at all. And then after that, they may get up, sometimes get straight up, and then fall right back down, depending on what they felt in the beginning. But typically we see the knee gets very stiff and it loses its ability to bend and extend. So if you pull your knee to your heel to your butt, that's knee flexion. If you kick your leg out and squeeze the thigh muscle on the front, that's knee extension. You're going to start to lose that, and then the knee starts to swell up a lot. The person is definitely going to feel instability when walking, and then they may feel like it's going to give way. Depending on how cavalier they are, the person may have their leg buckle up from underneath them when they're walking, and they may fall down. And then after that, their stride length, how big of steps they're taking, everything is going to start to get shorter. They're going to walk with a bent knee, and then their heel's just not going to strike the ground at all. And then from that point, we would say, please go to, if you're going to come see us, we're going to send you right to the doctor anyways. We're going to send you to an MD and get a diagnosis or imaging referral. But Dr. Pelivan, from those sequence of events, is there anything you want to add in there?
Yeah, definitely. It's a great starting point. I think one of the big things I always tell the patients, because they come in, I get a lot more kids that had a knee injury, but they feel better, but they want to get checked out. They're concerned about their ACL. I'll tell you right now, I've never seen an ACL tear, a true one, that in which the knee did not swell up and get what's called an effusion. All right. The knee joint is a closed area that's surrounded by a capsule. And again, with the ACL being inside the joint, it's surrounded by a bunch of blood vessels. When that tears and those blood vessels tear, they will bleed like stink, and they will fill up your entire joint with blood. It becomes like a balloon. Okay. If you see that, if you see this big swollen ball that where your child's knee was, that is very concerning and something you shouldn't sit on. If you don't see that, then there's a very good chance something isn't actually torn or damaged to the point where it needs surgical repair. We're more than happy to evaluate them, but I think that's your big immediate ticket to knowing whether something serious is going on or not. If you see a big knee swollen, big knee fusion, then there's something that's probably damaged. The other thing that people describe, it's a feeling that unless you've had your ACL torn, you'll never experience, but there are certain nerves on the ACL that are responsible for what we call proprioception. And proprioception is a term that describes our brain's ability to perceive where our limb is, our leg, in space without us actually looking at the leg. And you can imagine how important that is for soccer because, if you're playing at a high level, you're not staring at your feet the whole time. Your head's up, you're looking around, you're plotting your next move, what space you're going to run into, how you're going to make yourself available for your teammate, how you're going to defend a person you're marking. You're constantly looking around. You're not watching your legs. And so you're not thinking about where you're stepping. You're kind of moving on autopilot because the decisions you're making are, where am I going to pass the ball? How am I going to get the ball? What am I going to do when I get the ball? There's all these decisions going on every second of the game. And so proprioception allows your brain to autopilot where your legs go. And the ACL is so important for that. So when someone tears their ACL, all of a sudden it feels very odd for them to try to walk or run. They just can't understand why their leg isn't doing the things they wanted to because they lost a lot of that ability for their brain to determine where their leg is. And so it feels weird for them to run. They feel instability, buckling, etc. And so that's why it's very important to get the proper rehab, to train your brain again after an ACL reconstruction, to get that proprioception back so that you can prevent a secondary injury.
So Dr. Palaban, there's a question. Dara was saying that her daughter didn't present with swelling, but did in fact present with an ACL tear upon MRI inspection. I think it's important that to just note that not everyone's going to present the same way, but if the knee does swell, that is a big red flag. But not all ACL tears are going to present with a big swollen knee. Some of them might not. It also could show that the ACL might not be fully torn. It is also possible for the ACL to be fully torn and not swell up, but it's just a big red flag for you to know if it does swell up to a very large extent, that is an ACL should be concerned.
Yeah, exactly. No, I mean, again, it can definitely happen. I'm certainly never going to discount anyone that comes in and wants to get their knee evaluated because on exam, you can definitely determine if the ACL is out or not with instability, and MRIs are pretty harmless exams to get. But I think the big red flag, like you were saying, is if you see that swelling in the knee, don't try to play through it and don't try to ignore it and hope it'll get better by tomorrow. I think if you see that swelling, you should definitely get evaluated.
Yeah, I definitely agree with that, especially with younger kids who are a little less skeletally mature. We usually send them right away. People who are closer to being older or skeletally mature, if we don't see that swelling, we'll sometimes just keep them. But most of the times we're sending away for an image because that swelling can get in the way. But I think my next slide here, the one after this one, is going to talk about those mismatched expectations. And those mismatched expectations that we were talking about before. So we went through the sequence of events, and to recap, we ended up with the tear, and now we've got maybe a swollen knee. We got a knee that's buckling out from underneath us. So surgery, let's say, has been prescribed. So there was a study done that showed 100% of the people that were interviewed, they were going to have their ACL repaired, or they had it, and then they interviewed them retroactively. 100% of them went into the surgery expecting that their knee would be the exact same as it was before the surgery. But in reality, if you look at the next column right over, 42% of non-professional athletes end up returning to sport, which should be a gigantic indication that the knee did not return to the same level that it was before. 98% of those participants expected little to no increased risk of osteoarthritis. A very alarming number. 50% of people with ACL tears present at their 10 to 20 year follow-up if they have one with osteoarthritis in the knee joint. And it's a big conversation that I've had with different parents or different coaches. It's, your kid is playing soccer today, but there is a life after soccer. They're going to need that knee 20 years from now. So I understand that we want to get kids back to sport quickly, but we can't make decisions that are so cavalier that we put a kid at risk 20 years down the line because we need them to play a year from now or 7 months from now. A lot of patients that we've been seeing have been going into surgery with this expectation that they will be the next Adrian Peterson and they will be back to sport within the next 5 to 6 months. When in reality, any return to sport before 9 months has been associated with a 7 times increased likelihood that there would be a new tear, whether it's in the same ACL or the opposite ACL, which is a very important fact. I think any month that you go back to sport before 9 months, you are 52% more likely to experience another tear in the ACL. And then the last thing that we're hearing or just seeing from some patients is the things that they do before surgery, they just think that they don't matter. But in fact, preoperative and quite frankly, postoperative PT is going to define the quality of success. And you need a good surgeon as well. But it's a lot of work on the patient. So that expectation going into it should not be the surgery will fix me. It is the bridge between all the work I need to do to get back to sport.
Yeah, I send almost every one of my patients with an ACL tear to try to start rehabilitation, we call it, because the range of motion you have before surgery is very likely going to be how you end up. If so, you need to. It shows that you have such a better outcome if you can get full range of motion before surgery, and so prehabilitation, so working with PT prior to surgery and delaying the surgery about 3-4 weeks from the time of injury, has much better outcomes because a lot of people end up coming in and they have a torn ACL and it's only been a few days and they're like, well, we want the surgery as soon as possible, and the child can't even bend their knee, and so you're asking for a much worse outcome if that's the case. So that's the reason why we delay, try to get the swelling down, try to get the range of motion back, start working with the quad muscle, and then that way they have a much better outcome.
Yeah, that's very well said, Dr. Bellman, and I'm going to repeat that again. And a big trend with this presentation is that we're going to repeat ourselves because some of these things, they're just so important to hear. So after the initial tear, time is of the absolute essence, just like Dr. Bellman just said. So the first thing, rehab, we need to prepare for this surgery and we need to do it extremely well. Preparing for the surgery, if you look at the picture on the right, I'm going to say the quadricep muscle a few times now, and Dr. Dave is highlighting it with his cursor. So that muscle on the front of your thigh is the quadricep. And if we go down, Dave, we can show them knee flexion, which is on the left. That's your ability to bend your knee, and knee extension, the ability to extend your leg. We're going to talk about that a little bit. So the first steps, like we said, please go find a trusted surgeon, get an imaging referral. They will send you back to physical therapy to go for a month of prehab. And we'll talk about what we look for in that prehab. Because as soon as the ACL tears, that quadricep muscle on the front, it's going to want to shut off. It's not going to contract well. And the priority is to get it back on as quickly as possible before surgery. Because when a muscle shuts off, it starts to do something called atrophy or decrease in size. And the number one thing I tell patients is the easiest way to get back quad muscle after you tear your ACL is honestly to just never lose it in the first place. So if we go to the next slide, Dave. One big thing that you'll probably hear from PT, you're going to hear it from everybody. After you tear your ACL, you do not want to sleep with a pillow underneath your knee. Your child may say, hey, this is more comfortable, but the knee extension. So if we go back to that last slide, Dave, and we show them knee flexion. So if everybody here, if you can, pull your heel to your butt, that's knee flexion. And if you kick your leg all the way straight, that's knee extension. I promise you can walk without a whole lot of knee flexion. Try walking without any of your knee extension. You will have a much different walking pattern. That will be one of those things that ends up leading to osteoarthritis down the road. So we can go back to the last slide, Dave. And Dr. Pelleman talked about he looks for criteria to do before that he does the surgery. Here's the criteria we look for and a lot of people look for.
That's an important slide, though, you showed with the knee extension. That's the best way to get knee extension passively is resting that heel up with no space underneath the knee or nothing underneath the knee. So that way it can kind of use gravity to your benefit to kind of get that knee as straight as possible. Very important.
Yeah, that position right there. And I also just tell patients, squeeze your quad. Like if we're telling people to take 10,000 steps a day, squeeze that quad. You can't squeeze it too much before the surgery because it's a muscle that's already always being used. But we'll go to the criteria on the next slide, Dave. So we are looking to restore full knee extension and knee flexion, extension being more important in my opinion. We are looking for no swelling or very little swelling going into the surgery. It makes Dr. Belladon's job much easier if there's not a lot of swelling in the front of that joint. And the prehab that you do, all the quad squeezes, which we'll talk about, will help pull that swelling out better than anything else. Something else we look for is an ability for the patient to keep their leg perfectly straight while laying on their back. It's a good indicator that your quad is strong enough to fight against gravity. and we're looking to restore quad strength. There are some ways that we could measure this. We look for it to be about 80% strong as the other side before any patient goes into surgery.
The other thing about swelling is that whenever our bodies get hurt or damaged, there's a lot of what we call inflammatory markers or factors that are released from damaged tissue. And when your knee is swollen from having a significant injury like an ACL tear, it's full of these inflammatory factors that if you were then to do a second hit, which is then surgery, where you're drilling into the bone and reconstructing the ligament and such, you're just compounding the amount of inflammation inside that knee. And inflammation, unfortunately, leads to scar tissue. So there's a lot of correlation and good data that suggests that if you have swelling, if you do surgery too soon, then you do a second hit with surgery, and all of a sudden you get what's called arthrofibrosis, or just scarring of the knee joint, and it makes your range of motion return so much more difficult. So that's why it's important for us as surgeons to make sure you have good knee extension, good knee flexion, and that there's almost no swelling, and that we've delayed it long enough so that the inflammation inside the knee has died down, so that we're kind of starting from our baseline.
So that's really good information. The second must that we're going to look for is, again, we're going to try to get this quadricep muscle working as fast as possible. And again, we do not want to delay. We can go to the next slide. Like I said before, once this tear happens and after the ACL surgery occurs, we get something called quadriceps inhibition, where this muscle on the front, if you look at this guy, you can tell he's had some sort of knee surgery, most likely an ACL based on that scar. His right side is massive. The left side, that doesn't even, it looks like you put two different people in this picture wearing the same shorts next to each other. But that muscle is going to turn off very quickly. And once the muscle turns off and it's not being used, it will go away so much faster than you think. So the sooner we start to reactivate the quadricep, the less it's going to atrophy and the easier the knee extension is going to get. But I'm going to talk about that on the next slide. Again, quadricep, it's going to, the swelling process has to happen, contracting the quadricep to begin to pull all of that fluid out. And in my opinion, that works better than rest, ice, compression, elevation. Any ACL I've ever had, the people who are just doing elevation, they have these ice machines called game readies. When you're just relying on passive factors to pull the fluid out, we always just end up with this puffy knee. My patients who are just always squeezing their quad, they're working on it relentlessly, they're the ones who are going back for their follow-ups, and the surgeon goes, this looks amazing. We can see knee landmarks. We can see the bones. Like, it's just, the quad is going to be your biggest winner here. Stronger quadriceps, like I said before, are linked with reduced rates of osteoarthritis in the future. So if we can avoid that with the quadriceps, we absolutely must. And again, the quadricep is going to be the key muscle to restore normal walking post-ACL reconstruction. This actually is one of my patients. That is her 3 days post-op. Unfortunately, she was at school in Connecticut, so I didn't get to do her prehab, but I caught her maybe the final week before she went into surgery. And lo and behold, we got the quad going, swelling came down. This is her 3.5 months post-op. Her leg looks really good, and we have to consider, I'm training her pretty hard, so that left side is also growing at the same time. So that muscle has come back significantly. 3 months out, she's already running. I think she texted me, she's back at school. She ran a 6:30 mile, and I'm like, I think I need you to slow down, and that's why I want them to stay with me a little bit longer. But getting the quad going is going to be the biggest thing. And the final thing that I'm going to leave you guys with, or the second to last thing, is you need to care about how your exercises are being performed. You have to care about it, but you also need to go to a therapist who cares about it as well. So we go to the next slide. So this is one of my patients, Justin. He was totally cool with us sharing this image. So we were doing an exercise with blood flow restriction on with him. And he was obviously he's tired. The muscle doesn't want to work, but he's still early enough post-op where I need to be on him and make sure that the knee is creating the right angles. So if we look at the picture on the left, Justin is squatting with his knee. It's kind of far back. And when the knee is in that position, it's not activating the quadricep. In the picture on the right, he has good control of his foot, and I'm totally okay with where his knee is because that is where he feels the most quadricep burn. And if you watch any soccer game, or even if you go down the stairs, your knee is going to get close to the front of your toe. So we really want to promote in a close stance his knee coming forward so that he feels the quadricep, because that's the difference between when we go back and strength test the knee. Hey, did we actually make the quadricep stronger, or did we just spend 2 months actually training the hamstring and the glute instead? So we'll go to the next slide. We have a sled that we make our patients push pretty early on. It's a good way for them to show active control of their new ACL and knee extension. So in the first video, or the first picture here, if we don't look at Justin, I kind of had him pose for this one, but this is what it looked like when we started. He wasn't locking his knee out because that's just not the energy efficient thing to do at first. Your body is just like, let's continue to protect this. Like your brain is looking to protect you. We need to get this knee extending this the way it is in the right. And we need him to push that sled away from himself with a lot of purpose. It's these small details in exercises that make for good follow-ups with the surgeon afterwards. It is, did I pay attention to my exercise, the exercises they were doing? Did I care about how the angles were cued? And I know we put other soccer injuries into the presentation, but I didn't want to take away from the ACL. So if we go to that last slide there, Dave. How does this apply to other injuries? You can go one more. Every injury that we're looking at, everything is a little bit different, but these are our general philosophies. We need to restore the range of motion as efficiently as possible, as efficiently and safely as possible. We need to restore the strength of the surrounding musculature, and we need to pay attention to the angles that we are creating to ensure that the joint that's injured is getting the proper demand, but it's not being stressed for no reason. So I think that's all I have. I don't think I have anything after there. Dave, you can totally touch on what we do here at Next Level Physio, and then Dr. Pellerin can take over or whatever order you want to go in.
Yeah, I mean, essentially, you went over exactly what we do. There's a lot of purpose and intention behind everything that we do. We approach each patient and each session based on the patient's goals. I mean, a soccer player is very different from a lacrosse player. A lacrosse player is very different from, Nona Joan, who just wants to get up and down the stairs. So we are very intentional about the exercise that we choose, and we kind of approach things from a strength conditioning standpoint. And that's why we are working with NJ Crush, and that's why we are working with MSU Soccer, and I believe this is an NJ Crush girl. But there's very different demands for athletes, and our passion and our directive is to treat these athletes and get them to be as healthy and safe and have as much fun as possible. So let me just allow Dr. Pellerin to share his screen, and he could begin his process.
So thank you again for the first part of that talk. That was great information. I think a lot to take away from that for the parents and any athletes that are also going to be listening. So I am just going to be talking more about the surgical and science side behind it. I'm going to touch up on a few points that have already been said. So my name's Hakan Pehlevan in Ridgewood, New Jersey. I have no financial disclosures. I'm not being paid by anyone to be here. I'm volunteering, much to the dismay of my wife, who's taking care of our 3 kids right now, to be here. So a little bit about me real briefly. I trained, I went to undergrad, medical school, and orthopedic residency at UVA. Then I did my fellowship in pediatric orthopedics at San Diego, and it was an incredible time there. And then now I'm currently working in Ridgewood at Preferred Pediatric Orthopedic Surgery. I'm in my 4th year there now, partnered with Abram Jaffe, who some of you may have been to see for any injuries. So why do you need an ACL? This is a question that a lot of kids come in, they tear their ACL. We send them to PT, they get better, they get their range of motion back, they feel good, they have no pain, they have no swelling. And they look at me and they're like, why do I need this surgery? I don't need an ACL. I feel good. I'm ready to go play. The reason is because it's, like I was saying earlier, this is a very important ligament to the knee. And there's lots of complex motions of the knee. There's the flexion extension, which we've gone over. There's also rotation in the knee. Your knee actually pivots out and in, and externally rotates, internally rotates. It's just a small amount, so you don't really see it. But every time you're flexing and extending, your tibia is actually rotating on the femurs. And so that's another plane of motion. And then there's also translation. That means the tibia itself is sliding up and down with this slope. I don't know if can you guys see my cursor? Yeah, so this slope here, the posterior tibial slope, is what allows this femur to slide up and down on it. And that all has to be controlled to very fine amounts, because that's how the knee is functioning at such a high level, is because there's 6 different degrees of motion, or 6 different planes of motion. And the ACL is pivotal to make sure that when you're contracting and relaxing the different muscles, the quadriceps, the hamstrings primarily, that it's going along these planes of motions effectively. So when you don't have an ACL, it's no longer providing its check rein ability to prevent the tibia from moving only a certain amount. So it ends up moving further. It ends up rotating further. And that's the sense of instability that kids get when they don't have an ACL and they try to run, they try to pivot, they try to twist, and all of a sudden their knee, almost like they say, just gives out. Like all of a sudden their leg just buckles. And that's why. It's 'cause there's nothing there to stop it from going beyond its range that it doesn't want to translate as much as it does without an ACL. It doesn't want to rotate as much as it does, and then it gives out. And then because of that bad, kinematics or bad motion of the knee, that's how you get the arthritis. Okay, there's 2 reasons to getting arthritis after an ACL injury. One is the actual injury itself. A lot of times when you tear your ACL, your knee transiently dislocates, and you get the femur and the tibia colliding with themselves and causing a lot of cartilage damage. So unfortunately, you can't undo that. You can't take back the damage that's been done to the cartilage at the time of injury. But if you restore the ACL, you have good rehabilitation, you recover, then you can prevent further damage from occurring. Because if you don't have good motion or kinematics of your knee, then you're going to wear and tear and grind down the cartilage that you do have. And that's how you get early onset arthritis when you don't have an ACL. So here are the detrimental effects to not having an ACL. There's lots of different things that go on. Primarily, all the other ligaments are getting an excessively increased amount of force. You get a lot of inflammation from this abnormal movement. The forces can cause meniscal tears, other ligaments to tear. The cartilage is being worn down. So there's lots of reasons why, if you're going to be a high-level athlete, if you're going to do sports, then you need an ACL. Now, if a kid came into my office with a torn ACL and they're like, look, I play chess, I design computer software, I walk my dog, but that's it. I'm never going to run on a soccer field again. I'm never going to do this. I'm never going to do any sort of running, jumping, skiing, surfing, whatever. And you don't want an ACL? Could you get away with that? You could, but that's not the kind of life a lot of, parents want for their kids. So you want them to be active. You want them to be able to go out and do the things they want to do. And for that reason is why you need an ACL when you tear it. So in terms of the types of grafts, because that's a big question that comes up. Okay, I have a torn ACL. I need surgery. What is my surgeon saying to me? Like, oh, we're going to do a patella autograft. What does that mean? Okay. So autograft means from your own body. So that's your own tissue. Your cells are recognized by your immune system. There's no challenge to the graft that we put in or the reconstruction of the ligament, because the body immediately recognizes as its own, which is great. Okay. But the problem is you have to take that from somewhere. So it's a give and take relationship when you use autografts. Okay. Allograft, however, is from a cadaver. It's donated tissue. Okay. It's been radiated. It's been treated. So there's no chance of any disease, but however, the tissue is not recognized as your own. And so there's this delayed response where your body says, okay, what is this tissue doing here? It has to slowly convert it into its own tissue. That's the job. So an allograft actually acts more of like a scaffold for your body to slowly make a new ligament on top of it. Autograft, that process is a little more durable, a little more quicker. And that's why we prefer autograft, especially for, young athletes. So the studies have shown time and time again that when you're young, when you do sports at a high level, autograft is by far always the best choice. When you're older, if you're my age, tear an ACL, and all I want to do is run around with my kid in my backyard, I'd be better off with an allograft, because it's no reason to get an autograft from me. So in terms of the types or the locations, the one I use is hamstring, and that's one my partner uses as well. Okay, we take 2 of the 4 hamstring tendons. And a lot of times people ask, well, if you're taking 2 of my 4 hamstring muscles, does that mean my hamstring's going to be weaker? Initially, yes, it will. But however, the primary hamstring muscle called the biceps femoris is such a powerful hamstring muscle that when you go to guys like Nick and Dave to rehab, they focus on strengthening the hamstring muscles you do have left, and they can actually make up for the deficit of missing the two smaller hamstring muscles that we harvest for your hamstring graft. Okay. The other one is the patella, or what people call the BTB. That means bone, tendon, bone. Okay. That's when you actually go through the front of the knee. You take a piece of the bone from the patella. You take the central 1/3 of the patellar tendon, and then you take a piece of bone from your tibia where the tendon attaches. Okay. And you close that tendon together, and then you use those two bone ends with the patellar tendon as your graft. Okay. Also a great choice. To me, I think it has a little bit more morbidity. It's more invasive, bigger incision. A lot of kids complain about having knee pain afterwards, anterior knee pain. Could it be related to that? I think it is. So I find that hamstring for me works better. And then quadriceps is more of a newer graft site that's gaining popularity. It's more similar to hamstring than it is patella, but it's also great because you can do it with a small incision. You don't have to take any bone, and so there are a lot of surgeons out there that are actually trying to look to doing that more. For me, I'm very comfortable with hamstring. I have good results with hamstring, so that's what I stick with. That's what my partner sticks with as well. This is an example from the company I used. I supplement my hamstring autografts with this thing called the internal brace, this blue collagen lined fiber tape that basically becomes part of the graft. There's a lot of data coming out as part of the research when I was at Rady Children's Hospital showing the improved outcomes by adding this internal brace into our grafts. This is a newer technique over the past few years. And we're seeing much more success with this, much lower re-tear rates with hamstring autografts when we add this internal brace. So that's something that, we do at Preferred Pediatrics. We think it does a great job of supplementing the graft itself and providing more stability. So this is what an incision looks like when you get a hamstring autograft. You can see two tiny arthroscopic portals. There's an incision on the back of the femur on the outside here that's also about this size. And then you see this is where we harvest our hamstring. So it's not a major surgery. A lot of kids think they're going to get some huge whack that's going to go from the top of their knee all the way down. But, we had the technique and skill now to be able to do these surgeries, which there's a lot going on inside, but on the outside, you can see once they healed and you can't really see that much. This is probably the most important graft or slide that you're going to see. I show every single ACL patient of mine that I'm doing surgery. I bring this up, I put it on the screen, I make it full screen. I make them take pictures on their phone, and I say, this is the most important thing that I'm going to show you. And this is the reason why every time you ask me, can I go back to sports? And it's not time to go back to sports. I'm going to tell you to pull this up, and you're going to look at it and say, okay, you're right. I'm not ready to go back. So this is a great graph that shows that this is the strength of the ACL from a native ACL, okay? When we do a reconstruction, it's actually way stronger than an original or native ACL. Early on, though, okay? But there's this process called ligamentization, okay? Because we're taking what's called a tendon, which has a certain structure to it with the different collagen cells and fibers that make up a tendon and acts like a tendon, and we're turning that into a ligament. The body is slowly doing that, okay? So it has to break down tendon tissue and replace it with ligament tissue to make it in simple terms. And unfortunately, that process at around 3 months weakens the graft. And you can see now you go from a super strong graft in the first 3 months, but you're in a lot of pain, you're swelling, you're recovering. But then once you start to feel good, this is the challenge here. I get all my patients coming in at 3 months and they're just like, I feel great. Can I play? Can I go back? And then I tell them, look at the graph. Okay. If you go back to play, you are very likely to re-tear this. It's now weakened. All right. Way weakened. So the moment you try to sprint, cut, twist, kick a ball, you're going to immediately damage your knee and you're going to regret that because you're going to start all over again. Okay. So it isn't until about 9 months that you start to get the strength to come back. It's ligamentizing enough that then you can go on to, start training to go back to sports. So that's a very important chart. I showed that to everyone. I think everyone should be aware of that. Here's the other timeline progression. So again, you can see Another chart that I show my patients is how we work, to get to our goal at around 10 to 12 months is when we start doing return to play sports training. But until that time, even though you feel great, and again, a lot of times this is the hardest time, I think, is this 4 to 6 months mark when kids are like, I feel great, I'm ready. And we gotta do our job as parents, as surgeons, and as physical therapists, saying, no, you can't. You're at such a high risk for re-injury. Even though you feel great, you got to keep training. You got to keep working to get that quad strong. You got to go through the neuromuscular coordination to get your ability to again, move your leg in space, make subconscious decisions on how to run, how to twist, how to change direction, how to decelerate safely so that this injury doesn't happen again. So what are the reasons for refailure? Again, the biggest one, returning the sport too soon. That's by far the biggest risk. We used to, as surgeons, pride ourselves in, my patients can get back at 6 months, they're playing. And then we showed that actually that's not a good idea, because now we're getting a bunch of re-tears, okay? And as surgeons, we have our faults, not everyone has great technique. We may, I'm not saying there's mistakes that are made, but, not every surgery is absolutely perfect, but you want it to be. And so there's a little component of that where poor technique can lead to a failure, but ultimately returning the sport too soon is the biggest reason. Okay. Your quad and hamstring has to be strong. You have to go neuromuscular control of that leg. And again, you have what was a native ligament covered in native nerve tissue and native blood vessels that was completely replaced, and your body's doing its best to replace that. And that takes time. You got to work with your therapy. You got to work with the exercises they give you to train your brain to be able to control that leg again. Okay. Surgical technique. The biggest reason is the femoral tunnel placement. Back in the 80s and 90s, when ACL surgery was just starting off, they would be what we call transtibial, or basically they took the drill, started at one point of the tibia and just drilled it straight up all the way out the femur in one straight line. Okay. And that's how they replaced the ACL. It made it quick, it made it easy. But what we learned is that that's not really anatomic. And now we've been taking so much time, so much data, so much studying to figure out what is the actual anatomic position of the ACL, because that's what we try to recreate. Okay. And we're getting better at that. And we're getting, there's lots of research that still goes into it. But I think now it's much better in terms of getting an ACL replacement than it was, 20 years ago, 30 years ago. Even though there was a lot of good outcomes from that time, I think your outcomes are getting better. Graft choice is also important. I think all grafts in the right hands can be really good. Okay. So the graft you want to use is ultimately the graft that your surgeon's most comfortable with. So if, I don't think you should ever choose a surgeon based on the graft they use. You want to choose a surgeon and whatever graft they say is the best for them, then I think that's what you should go with. Okay. And then also just bad luck and inevitability, like we touched on earlier in the talk. 20 to 30% of the time after an ACL reconstruction, when you go back to a high level sport, you're going to re-tear or re-injure or injure the other side. And it's just the way it goes, unfortunately. If you stop sports, then you're probably not going to tear your ACL, but that's the whole point. The reason why we're doing surgery is to get you back on the field. All right, this next 2 slides, I'm going to go into the science behind why female athletes, I think, are a particular higher risk than male athletes, even though male athletes also get ACLs. There's some data in here that is just purely from the literature, orthopedic surgeons and medical journals. I have no opinions on what to do with this information. I'm not going to give any recommendations. I'm just going to show you the data, and because a lot of people ask why do women get more ACL tears than men? And this is, as we understand it, this is the reason. Okay. So you can see in the ovulation cycle, the week leading up to ovulation, there's this big spike in estradiol. A lot of these studies, we're looking at the rates of the time in which a female athlete who tore their ACL, where they were in their ovulation cycle. And you can see that there is a significant amount that showed that the highest risk or the highest rate of injury was in this pre-ovulatory phase, or this week leading up to the ovulation, okay? Because it's a spike in estradiol that led to changes in the physiology of the knee. The ligaments relax a little bit, and that's when you're at higher risk, okay? I'm not recommending or saying that you should sit your daughter and not play a week before their periods start. Okay, that's not what we're trying to say here. We're just showing the science behind why female athletes are at risk. Okay. This next slide is also looking at some studies that have looked at oral contraceptives. Again, I'm not going to make any recommendations based on what this is saying, but as you can see, there's been a lot of studies that looked at this. They looked at female and high school athletes and multiple studies that were on oral contraceptives and the rate at which they got injured with an ACL. Okay. When you see these words on the side here, poor, good, poor, these are the ratings in which the Orthopedic Journal of Sports Medicine, which is one of the highest impact factor journals for sports medicine that surgeons use. This is how they rated those studies. And you can see that a lot of poor studies show that there's no effect with oral contraceptives. And then there are some poor and good studies that showed it reduced the risk. Okay. One study, this one that's rated fair at the bottom, is the latest one that they said in high school to college age athletes, oral contraceptives reduced the risk of an ACL injury by 20%, likely because it's affecting that estradiol spike that we saw here, which leads to ligament relaxation, more likely to tear your ACL. Okay. Again, no recommendations are being made from this, but this is just information for you guys to have. And so that's how I'm going to end it. These are my 3 children. They're all very young, but I love them to death. And, one day maybe my daughters will be playing for the NBA Crush. You never know. And thank you for your time.
Thank you so much, Dr.
Any questions?
Yeah, I want to open up to questions for Dr. Nick or myself or Dr. Pelivan. PJ?
Yeah, sorry, I'm out walking the dog. So I'm out in the dark right now, but I've been listening to you guys. Love the information and love everything I'm learning tonight. One of the things, just thinking about our staff, when we're going through warm-ups and we're going through our normal daily sessions, is there something that we could implement to help limit the and bring the percentage level down for injuries like this? Maybe that's something for a separate talk one night, but definitely something for us to think about, maybe connect on soon.
I think stretching is the most important thing by far. That it's the easiest and simplest way. That's the most overlooked thing that an athlete can do is just stretch every day. Every female athlete that comes in, they have tight hamstrings, they're at risk for these types of injuries. I asked them, who's your favorite artist or musician? Okay, most of the time it's Taylor Swift or something. And I say, okay, in the morning, you're going to put on 2 Taylor Swift songs that you like. And I hand them a soccer stretching handout or whatever sport they're playing as the sport-specific stretches. And I say, I want you to stretch these stretches while listening to Taylor Swift in the morning and in the evening, every day. Okay, they have to do that every day. I think stretching is by far the most important. And when I talk to a lot of these athletes, I ask them, well, how much are you stretching at practice? They're like, well, the coaches, they kind of just, tell us to warm up and stretch on our own, and we do it as a team, and people take it not seriously and they don't do much. And so I think if there's one thing that you can change for every athlete that you come across is to teach them the importance of stretching, getting nice, balanced, stretched out hamstrings, quadricep muscles, because that relationship between those 2 muscles is by far one of the most important things when it comes to knee motion and kinematics.
Yeah, 100% agree. Sorry, Dave, you want to go ahead?
Oh yeah, and I know last year we also ran a program with NJ Crush doing some off-season training, and I want to stress how important it is also for these girls to be strong in different ways and to be able to absorb and have the capacity and resiliency in their tissues to be able to tolerate some of the stresses that happen throughout the season. And off-season training, I think, is extremely important as well. And off-season training that takes into consideration the positions and angles in which these girls have to perform.
Yeah, and PJ, I've seen how you guys have warmed the kids up in the past. I think you guys do the most important thing is get their body temperature up, because that's the easiest way to get more flexibility out of anything. So you guys are using People Lemon. You guys are getting their body temperature up gradually, getting them into more dynamic ranges of motions, and then you get them straight into practice. So I think you guys are already doing a really good job at that.
With Dara about cleats. Do we have any recommendations for cleats? I think one of the biggest things is wear the appropriate cleat, right? So if you're on turf, you need to wear a turf cleat. If you're on grass, you need to wear a grass cleat. Different surfaces have different kind of amounts of friction. So just make sure that you have the right cleats on.
And if you don't mind if I jump in here for a moment. So I wear a couple different hats. I'm also a consultant for a company called IDA Sports. And it's a Australian company, been around for about 5 years, just recently got into the US just after COVID, about a year and a half ago. And I've been just trying to help spread the word about their product. And there's again, I'm not doing a sales pitch here, but their science behind their cleat is actually helping to lower the risk of injury in players. It's not preventing anything, but it's actually lowering the percentage of risk because they're finding that the toe bed is a little bit wider for women as opposed to men, and the heel is actually more narrow. So when you wear a unisex boot or cleat, ultimately, you're putting on a cleat in the moment that's made for men and women. Where IDA is, they're ultimately specifically fitting towards women's feet. So they have a wider toe bed, more narrow heel. They're finding the placement of the studs on the bottom of the cleat are making a difference, and also the length at which those cleats are also making a difference. So the science behind it over the last 5-6 years and how they've developed the cleat. I'm not saying to buy it, but I would highly recommend that people at least go look at them. Dick's Sports, just go try them on over there, and if they fit, it's another opportunity. And the reason why I got involved with them was simply for a lot of things you guys mentioned tonight. I've been coaching obviously with Crush for years, and I coach girls varsity soccer as well. And I see year after year, unfortunately, players going down with ACL injuries. And I find if there's any way for us to prevent even one more girl, or one more female player, any player of anywhere, that we can lower that chance of them getting hurt, even if it's a cleat or exercises or stretching, whatever it's going to be, how we can bring that down and educate everybody, that's what we're going to do. And that's really the reason why I just wanted to mention that right now.
BJ, sorry, maybe like a follow-up question. And I know that you're at Saddle River Day. I guess my question is really like the difference in field surfaces, like how much of like an impact does that play on the rate of injuries, like grass versus artificial turf, all that? Because I know, like and again, I have a freshman high schooler and younger girls, and I never really appreciated the difference between the different cleat types, and how maybe that supports them or not, like on different surfaces. So I don't know how much that kind of plays into the rate of injuries, but I've kind of found myself now conscious of that and trying to encourage my daughter to wear artificial grass cleats on AG surfaces versus firm ground. So I don't know if there's a view on how much that matters, but
I have an opinion on it. I think, anecdotally, and I think other surgeons would agree, I think turf is not good for the athletes unless they train and play on just turf. I think the problems that kids run into is that if they train on one type of surface and their bodies are getting used to how much force and motion it needs to do the certain things they want to do, and then they play on a completely different surface, I think that's what throws off their ability to decelerate and change direction. And I find that the biggest, more injuries, especially in football players as well, happen on turf. I think for that reason, I think there's probably more grass than turf fields. And so most kids are playing on grass and they're used to how grass feels when they're wearing a specific cleat and training for their sport. And then they get onto a field that's turf. And if it's just a little bit slick, if it's a little bit humid and the surface is completely different to them, I think that it opens up a higher risk of surgery. Another thing I wanted to go back to and revisit was the type of cleat. I'm not paid by Nike. I actually don't like Nikes, but I just want to say that Nike is also looking into a specific cleat that is they're claiming is preventing or reducing the risk of ACL injuries. They're sending a lot of literature out to a lot of surgeons to review because it's coming out of Yale Medicine, where they are looking at the specific cleat design. The type of cleat is called the Phantom Luna. I think the U.S. women's national team wore it this past World Cup. I don't know if that worked out for them or not. I mean, from the baseline results, it didn't so much, but they claim this cleat can actually reduce ACL injuries. I cannot endorse it. I cannot say that I recommend it, but it's something for you to look forward if that's something you wanted to be interested in and read further about. That this IDA cleat is one to look at, and also the Nike Phantom Luna. It's not cheap. You're certainly going to pay for it, but if you're really wanting to try something, then that's one avenue to explore. Again, I have no recommendation specifically on the type of cleat. I think whatever is comfortable is the best. And then again, with the fields, I think if we could get rid of turf, I would love to. I think grass is definitely the way to go, but unfortunately that's the reality. They're going to be around. You can't really remove turf from everywhere that it's installed. It's very costly. And I wouldn't recommend you not play your daughter whenever you're going to a turf game or a field. So, it's just one of those things you got to be aware of.
So if there's any other questions, please speak now or forever hold your peace. If not, then we'll end the day. We want to thank you guys for your time. Thank you, Dr. Palavan, for your time as well.
Thank you for having me.
And Peter, we'll put this recording out. I'll share it with you, and you could share it with the rest of the NJ Crush family. Hopefully you guys have gleaned some really good information. I know I learned a lot as well. And we hope that you guys have a good night.
Thanks again, guys. Thanks so much.
Thank you, everyone. Have a good night.
Good night.